Hello everyone, I'm Dr. Diksha Goswami Sharma and I have done my MD GNB. I'm a member of the Royal College and a fellow of the Indian College of Obstetrics and Gynecology and a National Board Fellow in Reproductive Medicine. Currently, I'm the director of Pushpanjali IVF. We are based in Agra. And I'm also the North Zone coordinator for the Perinatology Committee of FOXY and a librarian in the UP chapter of ISAR. In the past few years, I have edited the Foxy Focus on Infertility in 2018 and have authored various chapters, including those in Springer publications like Principles and Practice of COS and ART by Dr. Surveen Guman, and a chapter in prestigious textbook on ART by Dr. Kamini Rao on oocyte and gamete donation, and various chapters like those on adjuncts in IVF, absolute asthenozoospermia, recent trends in embryo transfer in Foxy Focus. Today, my lecture is going to be on azoospermia. The points I'll be covering include the definition of what is azoospermia. I'll be enumerating the various causes of azoospermia, how to evaluate a patient who presents to you with azoospermia, how to differentiate between obstructive and non-obstructive azoospermia, and the various treatment options for such patients who present to you. Coming to the incidence, 1% of all men have azoospermia, whereas 10 to 15% of all infertile men would have azoospermia. It is defined as a complete absence of sperm from the ejaculate. We need to actually differentiate it here from aspermia, which means the complete absence of ejaculate. How do we diagnose it? When on initial evaluation, no sperm can be detected on high-powered microscopic examination of seminal fluid, then we must centrifuge the sample for 15 minutes at a high speed of 3000 G or more, and at least 2 samples must be examined 2 weeks apart for us to conclusively say that the man is azoospermic. Coming to the classification, the main 2 types are obstructive azoospermia and non-obstructive azoospermia. 1/3 of the cases are because of obstructive etiology, in which there is an absence of sperm secondary to a transport failure between the testis and the urethra. Whereas 2/3 of the cases would have a non-obstructive etiology, where there is failure to produce sperms in adequate number in the testis. These non-obstructive causes would include both primary testicular failure and that secondary to endocrine causes. When we talk about the etiology of azoospermia, we can also classify it as pre-testicular, testicular, and post-testicular causes. Pre-testicular causes are mainly the endocrine causes. These include hypogonadotrophic hypogonadism, hyperprolactinemia, and androgen resistance. There, the defect is mainly pre to the testis, that is at the level of the hypothalamic pituitary axis, and frequently these disorders might be correctable. Coming to the testicular etiology, these are the primary testicular failure and because of intrinsic disorders of the testis. The common causes include varicoceles, undescended testis, testicular torsion, mumps orchitis, gonadotoxins, and medication ingestion. If the man has some genetic disorders, then it will primarily affect the testicular production and idiopathic causes. These causes are usually irreversible except for varicoceles. Coming to the post-testicular etiology, these mainly include ejaculatory dysfunctions and obstructive pathologies. Obstruction of the reproductive tract of the male can be at the level of the vas. Most commonly, there can be an absence of the vas deferens. There can be vasal obstruction because of other causes. There can be epididymal obstruction or ejaculatory duct obstructions, and these causes are frequently corrected. And the other common causes of post-testicular azoospermia is retrograde ejaculation. Talking a little bit more in detail about the various causes, when we talk about the pretesticular causes, these comprise about 3% of the men with azoospermia. The subheadings of pretesticular causes are like I said, hypogonadotrophic hypogonadism. This can be congenital. Men with Kalman syndrome, usually these men will have anosmia with azoospermia. And because of the hypogonadotrophic hypogonadism, they have azoospermia. And you can test for if such men come to you, then you can test for the specific gene mutation to confirm the diagnosis. The acquired causes of hypogonadotrophic hypogonadism can be pituitary trauma, pituitary tumors, panhypopituitarism, or use of anabolic steroid. Hyperprolactinemia can also present with hypogonadotrophic hypogonadism. Usually, this is because of ingestion of medications like phenothiazines, antidepressants, methyl-dopa, and recepine. Medical illnesses like chronic renal failure and liver problems, and pituitary adenomas which secrete prolactin lead to hyperprolactinemia. The raised prolactin level in these men in turn suppress the FSH and LH levels, leading to hypogonadotrophic hypogonadism and consequently a reduced production of sperms and azoospermia. Androgen resistance. Complete androgen insensitivity syndrome usually presents as a phenotypical female, whereas a partial or incomplete androgen insensitivity male would present to you with azoospermia. When we talk about the testicular causes, these are mainly the intrinsic disorders of spermatogenesis. Here we see, like I told you about the more common causes earlier as well. Varicocele is seen in 5 to 10% of the men. When we talk about cryptorchidism, then there's a 30 to 80% incidence of azoospermia in case there is an uncorrected cryptorchidism, which can range like in unilateral cryptorchidism, there can be 30% instance, and in bilateral, there will be an 80% instance of azoospermia if not corrected. So it's important to counsel couples of babies with cryptorchidism to get a treatment at the correct time, preferably before 18 months of age. Mumps orchitis, a reduced risk is seen in mumps orchitis since the introduction of MMR vaccine, and it is usually not seen if a prepubertal child gets mumps. It's mostly if they contract in the postpubertal age group that they have a higher risk of having a azoospermia later. Testicular torsion usually results in azoospermia when the contralateral testis is also affected. So that if there's torsion in the other testis, then later on they can have azoospermia. Gonadotoxins, when we should include pesticides, solvents, drugs like androgens, anti-androgens, or if the male has had any history of radiation or chemotherapy. Coming to the genetic causes, the common ones are Klinefelter syndrome, XYY syndrome, XX males, Y chromosomal microdeletion, and mixed gonadal dysgenesis. We will be talking in detail about the more common ones a little later. Post-testicular causes of azoospermia are, like I said, obstructive azoospermia or ejaculatory dysfunction. Obstructive azoospermia, the obstruction can be at the level of the vas. The causes can be congenital bilateral absence of vas deferens, or a post-vasectomy if the male has had a vasectomy earlier, or any iatrogenic injury, especially the vas can be injured if there is a history of hernia or RP. In case of epididymis, congenital obstruction is known as Young syndrome. Usually these males will also have ciliary dysfunction, and thus respiratory infections will be, or pneumonia history will be there. There can be infective etiology, iatrogenic injury of the epididymis, or even scrotal trauma can also cause an obstruction. Then there can be an ejaculatory duct obstruction, which can be congenital if there's any Mullerian or Wolffian cysts. These are midline cysts which can obstruct the ejaculatory duct. Any calcification in the prostate, seminal-vesical calculi, infection-related scar tissue, and trauma are the other causes. Now, next we will be covering how to evaluate such a male who presents with azoospermia. Whenever we have a male who comes to our clinic with once we have diagnosed it, and confirmed the diagnosis, then we must go step by step. And the first step is to take a detailed history, because that will give us clue as to the etiology and how to counsel and proceed with the patient. The history must cover a history of past fertility, a complete medical and surgical history, especially if there's any history of pelvic or inguinal surgery like herniorrhaphy. Like I already said, this is important because there can be injury of vas or epidermis during such surgeries. Any history of childhood illnesses like viral otitis mumps, post-pubertal or cryptorchidism, which has been uncorrected. History of anosmia and repeated respiratory infections should be taken. History of any genital trauma, torsion, any proven or suspected genitourinary infections. Sometimes you can just ask them whether there has been any history of redness and painful swelling in the scrotal region. Any history of gonadotoxin exposures, it's important to know what is the occupation of the man, because there can be occupational exposure to solvents, to fertilizers, to chemicals. Any prior radiation therapy or chemotherapy he has received, any recreational drug or alcohol abuse, even in the past, or symptoms like headache, visual abnormalities, galactorrhea, and decreased libido, which might be suggestive of hyperprolactinemia. Coming to the physical examination. Once you have taken a detailed history, proceed with the physical examination. Examine the male in the standing as well as the supine position in a warm room, making comfortable. Uh, Assess whether the sexual development is complete, whether the features of masculinization are there, whether there's any sign of androgen deficiency. Saying that whether there's any history of infrequent shaving, how frequently he shaves would also tell about androgen deficiency. If there's any gynecomastia, unicoid features are suggestive of low androgen levels. Inspect locally for any scars, any scrotal swelling, whether there's any scar in the inguinal area. So you must also be examining from the inguinal area till the scrotum. Palpate the testes for the location, whether they are located in the scrotal sacs, both the testes, what is the size and consistency. There is also available of Prader's oxidometer, as you can see in the picture, and this can give you a visual. You can compare it and give a quite a objective evaluation of the testicular volume. Normally, testis is 4.6 centimeter in length and 2.6 centimeter in width, and the volume of a normal testis ranges from 18 to 20 centimeter cube. Very important is to look for the presence of vas, the consistency of vas and epidermis. Look for any nodularity or tenderness, which might suggest an infective etiology. If there's any varicocele, and then we can grade the varicocele as well. Whether the varicocele is palpable without valsalva maneuver, whether it is palpable only on exertion, or whether it is visible on inspection, even on inspection, whether the varicocele is available, is visible. The whole evaluation of the male will not be complete unless you also do a digital rectal exam, especially if there's no positive findings till now, and do a DRE for any mass, examine for the size and consistency of the prostate. Normally, the seminal vesicles will not be palpable. The next step, once you have taken a detailed history, you have examined the male, is to proceed with a hormonal evaluation. And the hormones which should be tested include the testosterone levels, the FSH or the follicular stimulating hormone, the LH levels or the luteinizing hormone, the serum prolactin, and the TSH should be tested. FSH more than 7.8 is considered as abnormal, while testosterone levels normally should be more than 298 nanogram per deciliter. So if it is less than that, then it means lower testosterone levels. Prolactin levels are important, especially if the male is giving any history of erectile dysfunction, because as said earlier, decreased libido can be a sign of hyperprolactinemia. And test for TSH to rule out hypothyroidism. Now, once you have all this information with you regarding the hormonal levels and the semen volume, even this much information alone can guide us towards what can be the etiology in such a male. In case of hypogonadotrophic hypogonadism, The semen volume will be normal or even can be low. We will be taking it all up a little later as well, while the testosterone and FSH levels will be low. If the male has had any ingestion of androgens, then the semen volume can be normal or low, while the testosterone levels can be normal, low, or even raised, and the FSH level will be low. In case of primary testicular failure, the semen volume will be normal, while the testosterone levels will be low and the FSH levels will be high. Because in primary testicular failure means hypergonadotrophic hypogonadism. Because the testis is failing, the FSH is secreted in more amounts to stimulate the testis to produce more sperm, so the FSH will be high. And despite that, the testosterone levels will be low, especially in cases of advanced failure. Though all the hormones can even be normal in cases of primary testicular failure. Coming to ejaculatory dysfunction or ejaculatory duct obstruction, that is an obstructive etiology, though the semen volume can be on the lower side, but the hormones will usually be normal. Similarly, in cases of vasectomy or epididymal obstruction, so basically the volume will just give an indication whether it's a higher obstruction or whether it's a lower obstruction. So if the obstruction is at the level of vas or epididymis, usually the semen volume won't be affected. Whereas if there's an ejaculatory duct obstruction or ejaculatory dysfunction, then the semen volume can be low, while testosterone and FSH will not be usually affected in cases of obstructive etiology. So this is the importance of a detailed semen analysis, evaluation of even the volume. Your analysis report should have the semen volume, the pH, the round cell. And in case of absence of ejaculate, since we have already covered like a low volume sample can be indicative of a retrograde ejaculation, we must repeat the semen analysis and also go for a post-ejaculatory urine sample analysis. Now, as we are getting more and more clues, how do we come to a differential diagnosis? When we are evaluating this male with azoospermia, the first clue will be by the examination. In case of vas is absent, then the clear-cut diagnosis can be made of a congenital bilateral absence of the vas deferens. This is usually a clinical diagnosis. You need not go for any other further investigations to confirm. However, in case the vas is present, then the further we can proceed whether the normal volume ejaculate or if it's a low volume ejaculate. Once we come to the low volume ejaculate, then we must do a post-ejaculatory analysis of the urine. Though at this point, we should also rule out other causes of low volume ejaculate, like if there has been any history of spill. So ask the male if there's any history of spill or if there's a very short abstinence period. Once you've ruled out, then go for a post-ejaculatory analysis of the urine. This is usually carried out after alkalizing the urine sample and then centrifuging. We centrifuge the urine at high speed and examine the pellet. If the pellet has presence of sperms, then the diagnosis of retrograde ejaculation can be clinched. However, if this is negative, then the other causes of low volume ejaculate include an obstructive etiology. So we can do a transrectal ultrasound to rule out obstructive etiology. In case a transrectal ultrasound shows dilated seminal vesicle, we can do a seminal vesicle aspiration and we can confirm for ejaculatory duct obstruction. Or if seminal aspiration is negative, then it can be a higher obstruction of the vas or the epididymis. Coming to the normal volume ejaculate, the next thing we have to see is whether the testis size is normal or the testis size is low. So if it's a small testis with a very high FSH, then its favor goes in the favor of primary testicular failure. That is, the FSH will be high, testosterone will be low, and the testis size will be less than 4.6 centimeter. However, with a small testis, if the FSH is low, then as discussed earlier, this is a case of hypogonadotrophic hypogonadism. Whereas, on the other hand, if the testis size is normal, then these are the cases in which we need to do a testicular biopsy to confirm between an obstructive or a non-obstructive etiology, which which we will discuss in the next few slides. Now, why is it important for us to differentiate between obstructive and non-obstructive etiology? Is not only for a sort of satisfaction to the couple as to what is the cause for the azoospermia, but also it helps in the counseling and prognostication of the couple. Both the types will have different sperm recovery rates, ICSI outcomes, that is the fertilization cleavage rates, as well as the outcomes of the pregnancy. Whereas the initial evaluation, like discussed, will help us differentiate to a lot of certain extent that the etiology is pre-testicular, testicular, post-testicular. Further workup is needed to clinch the diagnosis. A normal semen volume, normal testicular volume, and low testosterone and FSH is suggestive of hypo. So in this case, to find out what is the cause of hypogonadotrophic hypogonadism, we should also further do a serum prolactin levels and an MRI, because we have to rule out any pituitary tumors, that is prolactin secreting pituitary tumors or prolactinomas. In case of severe hypo, they can also be testicular atrophy and low semen volume. Like you saw in the previous graphs, that in hypogonadotrophic hypogonadism, the semen volume can be low and the testis size can also be small in case of severe cases. However, in such cases, if there's high testosterone levels in the presence of very low FSH-LH, then this is indicative of exogenous testosterone or anabolic steroid use. So differentiation between hypogonadotrophic hypogonadism, which is idiopathic or due to a hypothalamic pituitary cause, and anabolic steroids is by the testosterone levels. In hypo, the testosterone levels will also be low, whereas in cases of exogenous testosterone or anabolic steroid use, the testosterone levels will be high. Now coming to the evaluation of primary testicular failure. Primary testicular failure is suspected in men with small or normal volume testes. The FSH can be normal in such cases. Semen volume can be normal, but FSH can also be on the higher side once the testes completely fail. It is not necessary that FSH is high in all these men. There is limited utility of diagnostic biopsy, especially in men with very high FSH. What I mean by that is that if a male comes to you with a very high FSH, then we need not do a testicular biopsy just to confirm or conclude that he has primary testicular failure. Usually, testicular biopsy can be offered to be done at the time of ICSI so that we avoid two procedures for that. If offered, I would say it's a crime to do it without provision for cryopreservation if the sperms are retrieved. So just don't do a diagnostic biopsy. Make sure that you combine it with cryopreservation of sperms if retrieved. So where do we offer testicular biopsy? Going back even like what the graph, the table we showed before the flow chart. When the man has normal FSH, normal testes, and normal semen volume, where who can have either obstructive and non-obstructive azoospermia, then in these cases biopsy would help to differentiate. When we do a biopsy in cases of obstructive azoospermia, usually the histopathology will be normal spermatogenesis, whereas in cases of non-obstructive azoospermia, usually it will be either hypospermatogenesis, a maturation arrest, or a Sertoli cell only syndrome will be seen on histopathological examination. However, to reiterate, testicular biopsy should only be offered where it alters the further management. It can be done as a diagnostic procedure or as part of a larger fertility treatment. And once results are confirmed, you do a biopsy, you can send a quick section, let the embryologist see, and once he is confirmed that sperms are visible, and send another section to the lab for histopathology. If you suspect an obstructive etiology, then proceed with a further fertility treatment like a scrotal exploration or a corrective surgery. And if a non-obstructive etiology is suspected, then proceed with the sperm retrieval and cryopreservation of the sperm for further use for ICSI and helping the couple conceive. The next part of the lecture, I'll be covering that what is the role of genetic testing, which in which what all genetic tests should be offered and how it would help in your management. So, a karyotyping should be tested in all men with primary testicular failure. This will help to diagnose whether there are any structural or numerical chromosomal defects. Out of all the genetic causes which are possible, Klinefelter's is the most common chromosomal abnormality. And once the diagnosis of Klinefelter's has been made or genetic test, then further we have to counsel the couple regarding what are the rates of sperm recovery, what are the medical issues the man can have in the future, use of certain techniques which can help them improve their chance of conception, like microtessy, which is a microscope guided testicular biopsy for them. Also, sometimes we have to address that these males can have really low testosterone levels, which can affect their sexual life. So, treatment of those factors also have to be done. The next genetic test is that of Y chromosomal microdeletion. These are diagnosed in 15% of men. And we will discuss how a diagnosis of this, like how we should counsel. Genetic testing should also be considered in men with congenital hypogonadotrophic hypogonadism, as there can be some risk of passing it on to the offspring. Coming to Y chromosomal microdeletion, Y chromosomal microdeletions are basically deletion in the Azoospermia factor genes, and these three areas are the AZF, A, B, and C regions. And these regions of the Y chromosome contain several spermatogenesis candidate genes which affect the various enzymes and the various pathways of spermatogenesis. It is important to test for them because 15% of males would carry these deletions. And what are the implications if they carry a AZFA deletion, which is usually involves these two genes, and the histopathology in these would be usually Sertoli cell only syndrome. In the AZFB deletion, there will be primary spermatocyte arrest, and in C deletion, they can have foci of spermatogenesis. This means that while the chances of recovering sperm might be best in men with C deletions, but because these males, if we recover sperm from them and use them and they have a male baby, then there's chances of transmitting this deletion, AZFC deletion, to their progeny as well. So they can have boys who are infertile. Another important genetic test is for those with males with CBAVD, that is congenital bilateral absence of vas deferens. And we must test them for CFTR mutation, that is a cystic fibrosis transmembrane regulator gene mutation, because 50 to 83% of these men can carry this mutation. Even if the variant panel is negative, that means this panel usually will be testing for the most common mutations, the 23 common mutations. Even if negative, then we must do sequencing of the entire gene because many mutations can occur outside these. Why? Because this can have significant implication for the progeny. They have a cystic fibrosis. This gene is mutated in cystic fibrosis, and it has an autosomal recessive inheritance. So the female partner should also have the CF mutational testing if we detect the male partner, to avoid that the progeny have this very debilitating disease. Another nice table which helps us to differentiate and sort of recapitulates in obstructive azoospermia, indication will start from the history itself. There might be history of scrotal inguinal surgery, any infections. In case of non-obstructive azoospermia, any history of mumps, trauma, torsion, any uncorrected cryptorganism as a child, gonadotoxin exposures, chemotherapy, radiotherapy, always signify a non-obstructive etiology. On examination, the testis size will be normal in obstructive. In non-obstructive, usually it will be small and soft testis. The epidermis can be full or indurated in case of obstructive infective specialty pathology, and will be flat and soft in non-obstructive. The vas will either be absent like in CBAVD or can be beaded if there's an infective etiology. The vas will be present in non-obstructive. The secondary sexual character will be normal and obstructive, while can be absent or diminished and even normal in non-obstructive. The FSH level will be normal and obstructive. In non-obstructive can be normal or high. They can be, they will be a normal karyotype in obstructive, while in non-obstructive there will be abnormality in the genetic testing in 10 to 15%. There will be an abnormal karyotype. Now, just to like a little bit more about the differential diagnosis of azoospermia, and it is sort of a revision. Azoospermia with low ejaculatory volume, we've already discussed it before. Hypogonadism, we discussed it. Then CBAVD, clinical diagnosis, usually no further tests are needed. We can do an ultrasound scrotum if, sometimes you need to confirm, usually not needed. Or if obese, then we can do. Third DD is a retrograde ejaculation. This is diagnosed by presence of sperms in post-ejaculatory urine sample if more than 10 to 15 per high power field is there. Must test the urine after alkalizing it. Either we give soda bicarb tablets are given 2 to 3 days before the urine analysis. And in case all these diagnoses are excluded, then we can do LULOT obstructive etiology, that is ejaculatory duct obstruction with a truss. EDO is suspected. The various diagnostic, the features of EDO are that there will be an acidic semen, fructose will be absent in the semen. On truss, there will be many midline cysts, there will be dilated ejaculatory ducts and or seminal vesicles more than 1.5 centimeter diameter. If we really need to confirm, we can do a vasography, that is instill a dye, and if the seminal vesicles are dilated, then we can aspirate them under the same truss guidance, and if the presence of sperms in the seminal vesicles will confirm the diagnosis. The concluding part of this lecture will be about the various treatment options, and first we start with the treatment options for non-obstructive azoospermia. In cases of non-obstructive azoospermia, like we said, when we suspect non-obstructive azoospermia and we want to distinguish it, differentiate it from obstructive, then we can do a testicular biopsy. If the sperms are found, then yes, we cryopreserve the sperm and schedule the couple for ICSI procedure, either with TESE, that is a testicular biopsy, or a frozen TESE, that is we use a frozen sperm. If the sperms are not found, then depending on your availability and your resources, we can proceed with a microscopic testing. That is this dilated tubule seen under microscope sample. And if the sperms are found, then again go for use them for ICSI. If the sperms are not found, we can also resort to multiple biopsy. And if all the methods are unsuccessful, then the couple can be counseled to go for either artificial insemination by donor or for adoption. What about medical treatment? Now, medical treatment for non-obstructive azoospermia is only a viable option for those males who have hypogonadism. The treatment regime usually we start with HCG injections, 1000 to 3000 IU, which should be given 2 to 3 times a week till the serum testosterone levels normalize. If the spermatogenesis is not achieved in 6 months, then we add recurrent or urinary FSH, 75 to 100 IU 3 times a week. Usually, what is needed is to counsel these males that it does take some time. It can take even up to 2 years for spermatogenesis to return, depending on pituitary function. And especially in cases of congenital hypogonadotrophic hypogonadism, it can be, the patient needs to be very patient because it can take a long time for the effect to happen. Pulsatile GnRH via a Pump is another option, though it is less commonly used because it's not available in India. If there is inadequate response to medical therapy, then man can opt for ART procedures. Another promising approach of medical treatment is with aromatase inhibitors. These are effective in men who have low levels of intratesticular testosterone. And if you select those males who have estradiol to testosterone ratio more than 10, then they show a good effect to aromatase inhibitors. I usually like to test those males who have, especially those who are obese, and if the hormones are abnormal, then proceed with aromatase inhibitors. At least give for 3 months, 2.5 milligrams single daily dose. Coming to the sperm, various sperm retrieval methods, sperm retrieval and ICSI is a mainstay of treatment in non-obstructive azoospermia. Once we get the sperms, then these sperms can only be used via ICSI. And the methods which are available for sperm retrieval include TISA or testicular sperm aspiration, TESSE, which is testicular biopsies or testicular sperm extraction, and micro-TESSE, which is a microscope guided testicular sperm extraction. What are the pre-operative predictive factors for sperm retrieval? How do you counsel the couple that you have? What are your chances of getting sperms on a sperm retrieval procedure? One is histopathology. The best prognosis is seen in those males who have a previous report of hypospermatogenesis, while the worst prognosis will be for those who have a Sertoli cell only syndrome. FSH and testosterone levels are usually not predicted. So if you have a single FSH report, do not just tell him that you're not able to retrieve any sperms. You can try; they are not very predictive. What about the genetic etiology? Even in males with Y chromosome infertility and Klinefelters, there are 40 to 50% sperm retrieval rates which are documented in literature. So even in males with Klinefelters, but these rates are usually with a micro-TESE or a microscopic testicular sperm extraction, which will give the best results. Now, what about AZFC deletion? If you have tested the male and found out that this deletion is there, then like we said that in with C deletion, 70% we can get the sperms, while in A and B, it's a bad prognosis. Now, do we need to advise any interventions before going for a sperm retrieval procedure in ICSI? One is that role of varicocelectomy. So, if a male with non-obstructive azoospermia has a coexistent large varicocele, then recent reviews have shown that if we ligate the varicocele, then in 44% of these men, ejaculated sperm was seen. The benefit was most pronounced if they had a hypospermatogenesis, that is a favorable histopathology. If, however, sperms are present post-surgery, then we must cryopreserve. Even if post varicocelectomy in someone with azoospermia, there's not enough sperms in the ejaculate, but it is also shown that it improves the ICSI outcomes. And at least a 3-month gap should be done if you're proceeding with the ICSI for such a man. Then at least wait for 3 months after varicocele surgery. In men with non-obstructive azo and hypogonadism, that is a testosterone less than 300, there can be some benefit from medical treatment like anti-estrogens, aromatase inhibitors, and HCG before going for a sperm retrieval procedure. What about the success rates of sperm retrieval in non-obstructive azoospermia? With a TISA, we can expect 10 to 30% cases we will retrieve sperm, so it should be only chosen for favorable cases. With a conventional testicular biopsy, 35% cases, ranging from 17 to 45% cases we can get sperms, and with a micro-TESE, 52% success rates are there. Recent reviews have found that micro-TESE is 1.5 times more likely to retrieve sperms than conventional procedures, especially if the man has a Sertoli cell only syndrome. And normally an open biopsy is preferable to a TISA. However, there is no difference in outcomes of frozen and fresh sperms in men with non-obstructive etiology. But you have to warn them that sometimes we might not recover the frozen sperms and have to go for a fresh procedure again. Coming to the treatment options for obstructive azoospermia. In cases of obstructive azoospermia, if you're suspecting, and like going back to the flowchart, a normal volume, a normal testicular size, normal hormones, you want to differentiate. Then once you do the testicular biopsy, make sure that you have even the facilities for a scrotal exploration. If in scrotal exploration, if once a biopsy you suspect obstructive, go for a scrotal exploration. If microsurgical reconstruction is possible, then go for the surgical correction of obstructive azoospermia. If not, then go for a sperm retrieval. If sperm retrieval, the sperms are retrieved, then cryopreserve the sperm and use for ICSI. Coming to the surgical, what are the various surgical or microsurgical procedures which are done? The various procedures are a scrotal or inguinal vasovasotomy. So a vasovasotomy is where the vas, the obstruction is at the level of the vas. So the vas will be reconstructed with another portion of the vas, and this is usually indicated if there's a post vasectomy azoospermia, any iatrogenic injury, or a solitary vas obstruction because of any infection or trauma. Then there can be a vasoepididymoscopy, where a vas is being reconstructed with the epididymis. Usually, if there is an epididymal obstruction and the lot of epididymis is destroyed, then you have to reconstruct it with a vas. And best results in surgery are always seen in post-vasectomy patient. There is not very good results if there is an infective or a iatrogenic injury. So, what are the prognostic factors for success of post-vasectomy repair? Most important is that when you are doing a repair, during the repair, when you cut the vas for a vasovasotomy, if there is presence of motile sperms in the vasal fluid, then it's a good prognosis that your repair will be successful. If there is a shorter interval since vasectomy, what is the length of the testicular vas, presence of any sperm granuloma, the site of vasectomy, if the prior reversal has been tried in the surgical scale. In case of vas rupture, we usually change to a vasoepididymoscopy, and the patency of distal vas must be confirmed before the anastomosis. Patients should be counseled that if sperms are retrieved in the vasal fluid, then they should be cryopreserved. Complications are rare. They can be a reobstruction in 12 to 20% of the cases. Once you have done any surgery for an obstructive etiology, semen analysis should be done every 8 to 12 weeks. Surgery is considered to be failed if sperm do not return to the ejaculate by 6 months post-surgery, or 18 months. We should wait for at least 18 months after vasoepididymoscopy. Outcomes, the pregnancy rates have been achieved in as high as 76 to 30% of the cases. So post vasectomy case etiology are the ones who can be counseled for a surgical treatment. And the patency rate is almost as high as 97%, the highest. Other surgical therapies for obstructive etiology are for ejaculatory duct obstruction. The surgery of choice is a TURED, or a transurethral resection of urethral duct is done. It may be guided by a synchronous. We do a scan transurethral. Complications are seen in 20% cases include urinary tract infections, epididymitis, hematuria, there will be hematospermia, or watery ejaculate due to reflux of urine. Sperm is seen to return in the ejaculate in up to 70% of men, and 20% of the couples can achieve unassisted pregnancy. So, how do you decide whether we should go for a surgical sperm retrieval and ICSI directly or go for a surgery? When the etiology is a vasectomy or there are no coexisting female factors, then microsurgical reconstruction is preferred. While sperm retrieval with ICSI is a better choice when the female is also has an advanced age or a diminished ovarian reserve, when there's a coexisting female infertility, when there's concomitant secondary male infertility, that is, there are other factors in the male, or when the likelihood for success with sperm retrieval or ICSI is greater. A little bit more in detail about the surgical sperm retrieval and ICSI for obstructive azoospermia. Usually, this is indicated once surgery is not possible or fails. For obstructive azoospermia, the sperm retrieval methods are either a PISA, that is a percutaneous epididymal sperm aspiration, a MESA or a microsurgical epididymal sperm aspiration, a TISA or a testicular sperm aspiration, a TESE or a testicular sperm extraction, or a testicular biopsy. For obstructive azoospermia, there are very good success rates, a 90 to 100% sperm retrieval rate. The technique of sperm retrieval and the source of sperm does not have any effect on the pregnancy rates. Clinical pregnancy rates are about similar to any other etiology for ICSI and IVF. The last part, I would be discussing the various sperm retrieval method and the pros and cons. Uh, Like I said, the first is PISA or percutaneous epididymal sperm obstruction, indicated when there's obstructive azoospermia, where we are planning to get the sperms from the epididymis. In a microsurgical, we also doing from the epididymis, but with microsurgical methods. In obstructive azo cases, we do a MESA. Testicular sperm obstruction is indicated either if we fail to get sperms from the epididymis in obstructive etiology. If there's epididymal agenesis in CAVD cases, then we do for a TISA. If there's favorable testicular histopathology in NOA patients, or if there's previous successful TISA attempt in NOA patients, that is, if there's favorable prognosis in obstructive and NOA patients, then only we should go for a TISA. In failed PISA or TISA, or in obstructive azo, or in most non-obstructive azo, we should go for a testicular sperm extraction, either single or multiple random biopsies. And another next step is to go for a microsurgical, which can improve, but it depends on whether the facilities are available. Especially in Klinefelters, this is a procedure of choice. So what we do in a PISA, in PISA, which is used in cases of obstructive azo, the epididymis is stabilized between the thumb and index finger. We can use a loop to magnify, and we use a 13G needle inserted into the epididymis. The negative pressure is applied till with a syringe, which is pulled attached to the needle till the fluid enters the syringe. The aspirate is then flushed into sperm media. The PISA can be repeated at different sites of the same epididymis or collateral. And we can, if not got any sperms, then we can try the other epididymis. If PISA fails, then the next step is to go for a testicular sperm sample. What about MESA? MESA, the difference is we use an operating microscope, give a cord block, a small incision is given, the testis has to be exteriorized, the epididymis is examined, its covering is incised, and then the enlarged tubules seen under the microscope are dissected and opened. The fluid exuding is aspirated, which is supposed to be, and then flushed into the sperm medium. And similarly, we can repeat it in the other epididymis if we don't get sperms. So these are the pictures which show the Veris procedure for the. This is a picture which shows the epididymal sperm aspiration. What about TISA? Like we already discussed the indication in obstructive cases, if there's failed PISA, absent epididymis, or very fibrous epididymis, in non-obstructive as a diagnostic tool, or in favorable cases. So this is actually a picture which shows the TISA procedure. We use it. So how do we do it? We can do TISA is done with a butterfly needle, and we stabilize the testis. We introduce the butterfly needle in the testis. It's a blind procedure. The negative pressure is created with a syringe. Repeatedly, the testis is punctured with the butterfly needle, and then the tubules which come by the negative pressure in the syringe are then flushed into the sperm medium. TESE is an open testicular biopsy, and this single or multiple biopsies can be taken. It can be done without magnification also. Testis need not be exteriorized. The tunica is incised and then slightly pressed to, so that the testicular tissue pops out, which is excised and then sent to the lab or to the embryologist to see for the presence of sperms. This is a very nice picture showing the testicular biopsy procedure, whereas instruments or guns are also available for carrying out the testicular biopsy. A microtessay usually indicated in men with Sertoli cell syndrome, or if the conventional procedures have not been successful, it is done under microscope. A large mid-portion incision is given over a avascular area of the tunica, and then the dissection of the testicular parenchyma is done. The enlarged tubules or differently appearing tubules are the ones which are sampled, or random microbiopsy can be taken, 3 at each hole, and then we need to close the incision in layers. So this is the picture which shows the microtessay being carried out, where you can see a large incision and then a microscopic image of very magnified tubules, dilated tubules. So what are the various pros and cons? Quickly, recapitulating. When we do a percutaneous epididymal sperm aspiration, that is, it's a very fast, low-cost procedure, does not have much morbidity. There's not much learning curve to it, needs few instruments and materials, does not need any surgical exploration. On the other hand, the sperm number retrieved might be low, might not be able to cryopreserve them. Also, there can be fibrosis and obstruction later on at the aspiration site. Also, risk of hematoma, spermatocele is there. A MESA, on the other hand, a larger number of sperms are retrieved. There's excellent chance of sperm cryopreservation and reduced risk of complications like hematoma. And we can also simultaneously do a microsurgical reconstruction for obstructive etiology. Disadvantage is that yes, it's a more advanced procedure, a bigger surgery, more cost, time demanding, need more expertise, more instruments, and the post-operative discomfort will be more. What about a TISA? Similarly, for obstructive etiology of azoospermia, non-obstructive etiology, sorry, TISA will be fast, low cost, repeatable, does not need much expertise, few instruments, and patient can be discharged in 1 hour, minimal discomfort. But the number of sperms retrieved will be very low, especially for NOA, and cryopreservation will be limited. And because of the blind procedure, there can be risk of hematoma and testicular atrophy. While in tessay, though more expertise is needed, but in cases of tessay also, a lower success rate will be there in non-obstructive azoospermia as compared to a micro-tessay. In case of tessay, we will get more sperms when compared to a testicular sperm aspiration, and it is a procedure of choice for non-obstructive azoospermia. In microtessay, now newer studies say it is got the highest success rates in a way, with the largest number of sperms and highest chance of cryopreservation is there. But you need a bigger setup, you need a operating microscope, and you need more expertise. So, do the outcomes differ between obstructive and non-obstructive azoospermia? Yes, obstructive azoospermia has a better prognosis, like we said, almost 100%, while in non-obstructive it's like about 40-50%. Lower rate of fertilization and clinical pregnancy rates are seen after ICSI in non-obstructive azo compared to men with obstructive azo and ejaculated sperm. ICSI with surgical retrieved sperm, on the other hand, has been reported to be similar to ICSI with ejaculated sperm in terms of long-term safety. So we can reassure our patients that even though we are using surgically retrieved sperm, the ICSI outcomes and the pregnancy outcomes are very good. So thank you everyone, and I hope it has been a fruitful lecture for all.